Okay, good morning. Can everyone hear me? Wonderful. I'm Marissa Desimone. I am one of the moderators of this talk today with Dr. Amir Mohit. I am an associate professor of medicine and an adult endocrinologist at SUNY Upstate Medical University, and I am very happy to have you all here with us today for our exciting talk, What is the Deal with Type 2 Diabetes and Cystic Fibrosis-Related Diabetes? This is an emerging area of clinical and research interest as we see an increased number in patients with obesity, and we need new ways of treating them. So our 4 talks today are going to cover our current understanding of the link between type 2 diabetes and emerging data on the impact of highly effective modulators on metabolic disease, glycemia, as well as potential use of type 2 diabetes medications. I would ask that you please post your questions in the app. We are going to be monitoring that. If you do find the app challenging, you could just raise your hand and we'll call on you, and then you could stand up and ask your question. I'm going to get things set up for our first speaker today, Dr. Scott Blackman. Unfortunately, he was not able to come and join us in person due to something that came up at the last minute, but he was very kind to record his talk, so we're going to get to see him deliver this information. And just as an introduction, Scott is an associate professor of pediatrics at Johns Hopkins University, and his talk is on the genetic link between type 2 diabetes and CFRD.
Hello, my name is Scott Blackman. I'm from Johns Hopkins University. I'd like to thank the organizers of the session, Dr. Mohit and Dr. Desimone, for the opportunity to speak to you in this forum. I've been tasked to discuss the genetic link between type 2 diabetes and CF-related diabetes. I have nothing to disclose. So I've been talking about type 2 diabetes and CFRD for some time, and some of the common questions I get related to genetic overlap. Okay, so number one, more related to modifiers, isn't CFRD just caused by having CF? And the answer is yes and no. Eventually, most people with exocrine pancreatic insufficiency, or PI, CF, will get CFRD, but the age of onset varies widely from as young as 10, or perhaps even younger, to about age 60. The reasons for this variation mostly include not only non-genetic factors such as organ transplant, but also genetic modifiers. Okay, question number 2. Does overlapping genetics mean that CFRD and type 2 diabetes are the same disease? Short answer, no. We'll talk about that. Does this mean that CFRD is caused by insulin resistance? Well, actually, neither type 2 diabetes nor CFRD are really primarily diseases of insulin resistance. CFRD is a disease of insufficient insulin production, and so is type 2 diabetes. So, big question, does this mean that people who have CF and obesity and diabetes, that's actually CFRD, or is it type 2 diabetes? Well, that's kind of why we're here, isn't it? Okay, so I want to try to orient the audience to type 1 and type 2 diabetes as it relates to CFRD. So type 1 diabetes makes up about 5% of all types of diabetes in the world, or all people with diabetes. It's an autoimmune disease that is associated with destruction of the pancreatic beta cells over time, causing complete absence in most people of insulin production. The age of onset tended to be children and young adults, hence the previous name of juvenile onset diabetes. Shows up in people of all body mass indexes, which in the US, about half of whom are going to be overweight or obese just by chance. Complications of type 1 diabetes and type 2 include microvascular disease, which is retinopathy, neuropathy, and nephropathy. macrovascular disease, which includes essentially cardiovascular disease, heart attacks, and strokes. Type 2 diabetes, typically a disease of adults, especially over 40, hence the old name of adult onset diabetes. But now in pediatric endocrinology, about half of our teenagers with new onset diabetes, it's actually type 2 diabetes. So type 2 tends to show up in people who have overweight or obesity. It is a disease which also includes usually decreased insulin sensitivity with, at first, increased insulin production to make up for the insulin resistance, but then over time, the insulin production is insufficient and then even decreases. And that is the difference between insulin-resistant obesity and type 2 diabetes with obesity. Islet amyloid is a peptide that is deposited in the pancreatic islets that is present in people who have type 2 diabetes and CFRD. CFRD, as many of you are in the audience are familiar, is a disease which can show up in teenagers and young adults, does get more common with increasing age in people who have CF. It occurs mostly in people who have normal BMI or thin BMIs. It is a disease of decreased insulin production, not really that much decrease in insulin sensitivity, except for perhaps temporarily here and there. Islet amyloid also present, a feature suggesting some pathologic overlap with type 2 diabetes. And then the reason why we're here. Complications of CFRD, yes, it does include microvascular complications, and then perhaps maybe one day even macrovascular complications. But the main reason that we are concerned about CFRD is because it causes worse lung disease and earlier mortality to our people who have CF. Okay, let's backtrack a little bit. What is type 2 diabetes again? So it's a slow progressive decline in insulin production. It takes place over years to decades. It occurs in increased age. Certain races and ethnicities have higher risk. Family history and genetics are known to play an important part in type 2 diabetes, as I'll show on the next slide. And another obviously major risk factor is obesity, physical activity, nutritional status. Onset of type 2, like CFRD, can be asymptomatic, but can also present with severe acute insulin deficiency and diabetic ketoacidosis. So, phenotype clustering analysis. So this is ways of looking at different levels of insulin sensitivity or insulin secretion or obesity. And this type of clustering analysis has suggested at least 5 different subtypes of diabetes, really just based on phenomenology. However, this has been somewhat consistent. Genetic heterogeneity also exists, so there are different genetic risk factors for type 2 diabetes, some of which don't exist in certain populations, and yet those populations still have their own versions of type 2 diabetes. So there probably are lots and lots of different ways to predispose to type 2 diabetes. And so type 2 itself is probably a very heterogeneous disease. Okay, genetics of type 2 diabetes. Heritability studies show that the majority of the variance in type 2 diabetes risk is due to genes. And we know intuitively that this is the case when we find that family history is also a potent risk factor for type 2 diabetes. The first GWASs identified a number of risk loci for type 2 diabetes, including the ones listed here, TCF7L2 being the one that I'm going to call out. Remember that, you will see it again. Subsequent studies involving tens to hundreds of thousands of individuals have now identified more than 240 loci containing at least 400 independent signals for type 2 diabetes risk variants. Much of the time, not all of those variants have an obvious known function, but when the function can be guessed or is known or hypothesized, most of those variants are involved in insulin production or beta cell function. There are also type 2 diabetes risk variants involved in insulin sensitivity, and there are some that are also not directly involved in type 2 diabetes risk, but instead increase the propensity for obesity or overweight, such as FTO, and then mediate the risk of type 2 diabetes based on that. On the right side of the screen, I'm showing you a pancreatic beta cell with a number of the genetic risk factors for type 2 diabetes highlighted on here, indicating again that of the risk factors that we know a function, Many of those are involved in pancreatic beta cell function. Okay, let's return to CFRD. By comparison to type 2 diabetes, CFRD, also a disease associated with slow progressive decline in insulin production, takes place over years to decades, increasing age, females, CFTR genotype severity, genetic modifiers, and then non-genetic factors like liver disease or organ transplant. The onset, like type 2, can be asymptomatic, but can also present with acute diabetes symptoms, although CFRD is rarely associated with DKA. Okay, genetics of CF-related diabetes. The most important is the big gene in the room. CF is caused by deleterious variants in CFTR and CFTR genotypes, which can confer some residual function, leading to pancreatic sufficiency, reduce the risk of CFRD by about a factor of 20. This is illustrated on this slide, which is derived from data from the University of Minnesota CF Center. The risk of CFRD is on the y-axis, the age is on the x-axis, and you can see here, in people who have severe CFTR genotypes, that cause pancreatic insufficiency, such as delta F508 homozygous, about 80% of those people had diabetes by age 50. People who have mild CFTR genotypes that cause pancreatic exocrine insufficiency, only about 20% of those had diabetes by about age 50. But even that is a higher risk than the general population in Haynes for type 2 diabetes. We can also take a look at a data set here from the CFTR2 study. This is a CF Foundation funded study with more than 100,000 participants worldwide, and many of you in the audience are CF centers that have contributed data to the CFTR2 project, headed by Gary Cutting, and a large consortium. And in this, we took data for 2 typical CF causing variants, delta F508 homozygous and delta F508 in combination with G542X. And you can see that starting at about age 10, people got diabetes, and then by about age 60, more than 99% of people had diabetes. And the age-dependent risk of CFRD was identical for these 2 typical severe forms of CF. By comparison, delta F508 A455E, which is a typical pancreatic sufficient causing CFTR genotype, was associated again with much lower risk of CFRD, but still approaching more than half by about age 60. We did the same for a number of different CFTR genotypes, and here are the ones that were shown in combination with delta F508. Rather than take you through this slide, what I'm going to show on the next slide, I've collapsed each one of these curves down into a single point. And I've plotted each single point as a function of that CFTR genotype's sweat chloride. So each point here is a CFTR genotype. Delta F508 would be up here, along with this cluster of other severe CF-causing genotypes with a sweat chloride of around 100, 110. What you can see is that CFTR genotypes that are associated with progressively lower sweat chlorides, that is progressively higher residual function, result in really a continuous decrease in the risk of CFRD without really any kind of step off. So there's not really a pancreatic insufficient, pancreatic sufficient division line here. Rather, for every increment here in the CFTR function reflected by the sweat chloride going down a bit, result in a factor lower of the CFRD odds. So CFTR is clearly an important determination, but out of those who have pancreatic insufficiency with sweat chlorides up there in the hundreds, we showed first in 2009 that genes elsewhere in the genome really then become the most important factors. We then went on to show, and I'm not going to show you a lot of these data yet, in this talk, but some risk genes for type 2 diabetes play a role, including a family history, including TCF7L2. And then I'm also going to show you in this talk where you can combine different single variants that are associated with type 2 diabetes into what's known as a polygenic risk score. Now, CFRD is also caused by genetic modifiers that don't have anything to do with type 2 diabetes. And here's an example of that, SLC26A9, not a type 2 diabetes risk gene as best we can tell, clearly a CFRD modifier, as well as a meconium-ileus modifier. And so that has also led us into some work that I'm not going to be describing in this talk that demonstrates genetic overlap between CFRD and meconium-ileus. Okay, so the data that I'm going to show come from the International CF Gene Modifier Consortium, which is a group out of Johns Hopkins, Toronto, UNC Case Western, French Genome Consortium, as well as groups out of Denver, Wisconsin, and Boston. We had approximately 6,000 people who had CF in the study, half of whom were Delta F508 homozygous, and about half of whom were female. Okay. This is what's called a Manhattan plot. You may have seen these before. So this is one way of plotting genome-wide association results. The entire genome is on the x-axis. Each dot is a variant, and the level of significance is on the y-axis. And you can see what stands out here is a number of SNPs here in a locus that I've called TCF7L2. So these are within and around the TCF7L2 gene. That's, as I said earlier, one of the well-known type 2 diabetes risk genes, now here showing up solely based on statistics as a CFRD risk gene as well. SLC26A9 and PTMA are showing up here as CFRD risk genes. These are two risk genes that, as best we can tell, don't have anything to do with type 2 diabetes. So again, overlapping but not the same genetic risk. Okay, so remember I told you that there were more than 400 risk variants for type 2 diabetes. So you can combine those into what's called a polygenic risk score. One of the very easy ways to do this would be simply to add up the number of risk alleles that each person has, and then we would call that their type 2 diabetes risk score. You could also do it a little bit fancier by weighting the polygenic risk score essentially by the potency of the risk factor. We've done that. We've done it both ways, but the one I'm going to show you is the weighted type 2 diabetes risk score constructed from around 200 variants associated with type 2 diabetes. And as you can see here, most people fall in the mid-range of risk, but some people have genetically lost the type 2 diabetes lottery and have very high risk for type 2. Some people have genetically won the type 2 diabetes lottery. Okay, if you do that and stratify our people with CF who do and don't have CFRD are now being stratified by their genetic risk for type 2 diabetes. And if you do that, you can see that people who have the genetically highest risk for type 2 diabetes, about 50% of them got diabetes by around age 30. Those who had the genetically lowest risk for type 2 diabetes, about 50% of them had diabetes by about age 50. So a roughly 20-year difference. I'm not showing you the data, but you will also be left with significant differences in CFRD risk, even after you take out all the known variants, such as TCF7L2, that we are calling previously known CFRD variants. So a number of type 2 diabetes variants are associated with CFRD, including some, at least, that we have not yet individually identified. Okay, you can also do the same game with other traits. So we can generate genetic risk factors for type 1 diabetes, for insulin resistance, for insulin secretion, and so on. And if you do that, you find, so as I said in the last slide, genetic risk for type 2 diabetes is highly associated with CFRD. Genetic risk for insulin secretion is associated for most of the measures with CFRD. Genetic risk for 2-hour plasma glucose, fasting glucose, also some signal there. Maybe a little bit of signal for type 1 diabetes, more or less unexpectedly, but we can talk about that if you're interested. But what's very clear is that there is no evidence that genetic propensity for insulin resistance is associated with any up or down risk for CFRD. Okay, so in summary, type 2 diabetes is a genetically heterogeneous form of diabetes, occurs with increasing age like CFRD. Insulin production might be increased, might be normal, but eventually it's low, and anyway is inadequate at any stage of the game to meet the increased insulin requirements generated probably by obesity in most people. The genetic risk factors for type 2 diabetes tend to cluster. They might be insulin secretion, they might be insulin sensitivity, they might cause obesity, or there might be unknown function. CFRD. CFRD is caused by severe CFTR dysfunction, plus the effects of genetic modifiers. Genetic modifiers include not type 2 diabetes related genes, as well as type 2 diabetes risk genes, especially or exclusively even those causing defective beta cells or defective insulin secretion. And while, again, most of the variance in CFRD onset is in generally healthy people with CF is caused by genetic factors, you can also have non-genetic factors such as organ transplant that can play an important role. Okay, and what does overlapping but not identical genetics mean? So I like to think of it as people who have genetic risk for a faulty beta cell or poor insulin secretion. Those beta cells then would be programmed to malfunction in the setting of obesity, in which case you might have type 2 diabetes, or in the setting of CF, in which case you might have CFRD. People who have genetic risk for obesity or genetic risk for insulin resistance, well, those people would appear to be at increased risk for type 2 diabetes, but really not at increased risk for CFRD. So again, overlapping genetic risk factors, but not identical. Okay, so let's come back to the questions. So common questions I get related to genetic overlap between CFRD and type 2 diabetes. Again, is CFRD caused just by having CF? I think we've shown. Severe CFTR dysfunction causes pancreatic insufficiency. That's an important risk factor, but even then, among those roughly 75% of 80% of people with CF who have pancreatic insufficiency, as long as they don't have another obvious risk factor like a lung transplant, then CFRD onset is now determined mostly by genetic modifiers in that large group. Overlapping genetics, does that mean that CFRD and type 2 diabetes are the same disease? No. Does this mean that CFRD is caused by insulin resistance? So again, insulin resistance may contribute to both CFRD and type 2 diabetes, but the underlying cause is probably a beta cell dysfunction in most people. Most people with obesity have insulin resistance, but don't go on and get type 2 diabetes. Okay, does this mean that people with CF who have obesity and diabetes have CFRD, or do we call it type 2 diabetes? So again, great reason to discuss. I'm going to put my 2 cents out here and posit that perhaps what label we use may not be as important as really deciding how to individualize treatments based on what the patient is telling us. So with that, I will conclude. I'd like to thank the investigators in the International CF Gene Modifier Consortium and the CFTR2 study, some of whom are listed here. I'd also like to acknowledge the CF Genome Project investigators. I'm one of the PIs of the CF Genome Project, which is actually our ongoing descendant and active project involved in looking at whole genome sequence data in people who have CF. The investigators and institutions on the screen here, a number of talks and other presentations at this meeting and previous CF meetings, and I encourage you to seek them out. Thank you very much.
I'm really glad having Dr. DeSimone as a co-chair, because between the video talk and regular talk, we have to make some changes, and she's much more tech savvy than I am. So. So it's my great pleasure to introduce our second speaker of the session. Our next speaker is Dr. Rabasa-Lhoret. He's a professor of medicine and nutrition at the University of Montreal. He's well known to the CF community for his work in CFRD, and he will be talking about the role of insulin resistance in CFRD.
Thank you very much. Merci beaucoup. So yes, I will try, and it's a bit hard to be just after Scott. The presentation was of an excellent quality, and not only the quality, but my English will not be at the same level. You might know that in Montreal we speak French usually. So here are my disclosures. Oh, I already scrapped the system, is it? Let's try it another way. Yes, here are my disclosures. Just to tell you that I'm directing a large team, and I did had some relationship 3 years ago with the Vertex company. So the objective I was given by the committee, and I really want to thank the organizers for inviting me, was to revise some central role of reduced insulin secretion. It will be extremely brief, and Scott already covered this. Established here, we do have some evidence of measured insulin resistance in people living with CF to see eventually if that insulin resistance, if it exists, do contribute to glucose abnormalities. And to discuss very briefly, because there will be other talks on this, the potential role for management. So here is one of the graphs that show all the complexity that can lead to diabetes. But if you go to the bottom of the graph and you look to the things that are very close to the onset of diabetes, obviously decreased insulin production is absolutely central. But you can also see on those graphs that decreased insulin sensitivity might also play an additional role. So as Dr. Blackman showed, we have a lot of, the most frequent form of diabetes by far is type 2 diabetes. And on those kind of graphs, you have on the vertical axis the ability to secrete insulin. If you're high, you secrete a lot of insulin. If you're low, you secrete few insulin. And on the horizontal axis, you have insulin sensitivity, which is the other coins part of insulin resistance. So if you are around 6, 7, you're extremely insulin sensitive, your insulin work very well in your body. If you're more around 1, 2, you're extremely insulin resistant. So people with type 2 diabetes, as Dr. Blackman alluded already, are having both reduced insulin secretion, the blue arrow, and also reduced insulin sensitivity, which is similar to increased insulin resistance. So we know from this disease that it's a combination of the two. So to measure both insulin secretion and, more importantly, insulin resistance, which is the topic of the talk, you need, the golden standard is euglycemic hyperinsulinic insulin clamp. To keep it simple, this is a more than 3-hour test with 2 IV lines, every 10 minutes glucose. You need a nurse. It's a very complex test. So we tend to use, and usually, surrogate indices, but we need to acknowledge that though for insulin secretion, some of them have been validated in CF. To my knowledge, none of the insulin-resistant surrogate indices that you can use either from fasting samples or during an oral glucose tolerance test have been validated in CF. So we are already skating on a quite thin ice. So is there evidence that insulin resistance has been documented? Acknowledging that those tests to really measure in a very good fashion insulin resistance are complex to do, thus limited to small studies, we do have studies suggesting that CF people are more insulin resistant, which means the same that they have less insulin sensitivity than control. In the 2 next slides, this slide and the next one, the lower the bar is, the more insulin resistant you are. So you can see on that slide 20 years ago that people with CF are actually less insulin sensitive / more insulin resistant than are people that are normal healthy controls. Within the group of people with CF, it seems that the one that do have some glucose intolerance, we call sometimes pre-diabetes or impaired glucose tolerance. So their glucose level, specifically after an oral glucose challenge, is already a bit high, but not in the level of diabetes, but not anymore in the normal level. We see that those people, the bar is lower, they are more insulin resistant, or again, they are less insulin sensitive. As Dr. Blackman alluded, there are multiple reasons in people with CF that could explain that a person living with CF could be more insulin resistant than someone not living with CF. Hyperglycemia by itself can do this. When you have a largely reduced pulmonary function, you probably have more sedentary behavior, where there's a well-known chronic inflammation and so on. You can go all around. All those factors have been identified, and as Scott just shown, some type 2 diabetes gene also with the overlap have been demonstrated, usually not directly in CF, but in other occurrence, for example, exacerbation of pulmonary obstructive chronic disease, to increase significantly insulin resistance. And the most characteristic one would be the use of steroids. Usually the respirologist goes first, and then other non-CF things give a lot of steroids to the patient, and the day after, the endocrinologist is called in emergency ward. That's the normal sequence about this. Since corticosteroids is the best way to create insulin resistance, we use it in the lab. So is this actually translating into CF? So I've used cohorts I know way. It's one of the cohorts we have in Montreal. It's a prospective, it's observational, so no causal effect can be derived from this. It's only strongly suggesting. It has over 300 people with CF. It has an overall follow-up close to 20 years, and we have repeated measures of glucose tolerance from which we can use indices to measure insulin secretion, to estimate, I should say, insulin secretion and insulin resistance. And once again, we're using indices for insulin resistance that have not been specifically validated for people living with CF. So here's one of the papers we made. The idea was to understand why there is that huge variation of glucose tolerance from one test to another, which is a use frustration. So it's a bit more than 150 patients. It is a bit less than 2-year follow-up. And you can see that if you are NGT, normal glucose tolerance, you can either remain NGT, the blue arrow, or you can go to either IGT, prediabetes, or de novo cystic fibrosis-related diabetes, the 2 red arrows. If you already have some degree of glucose intolerance, IGT, impaired glucose tolerance, you can either improve, the green arrow, remain stable in that prediabetic state, the blue arrow, or get worse, the red arrow. So this is something that is driving crazy any endocrinologist, and probably even more any patient and all CF teams. From one test to another, you have close to half of the patient that change glucose category, so you never know exactly where is the target. And the question we were trying to answer here, is it the progression of insulin secretion deficiency, or is it the occurrence of some insulin resistance that could explain such variation? And actually, the people who remained stable, they had no change neither of insulin sensitivity or insulin resistance, while the one that improved their glucose tolerance, for example, from impaired glucose tolerance to normal glucose tolerance, improved their insulin sensitivity with no change of insulin secretion. And conversely, the one that went, for example, from normal glucose tolerance to IGT or de novo diabetes had no progression of their insulin secretion defect, but they became more insulin resistant. So in the context of low insulin secretion, which is the driving factor, it might be possible that relatively modest insulin resistance could have some quite significant impact on glucose tolerance. Let's look to it on a different way. And I'm a quite active physician, so that study really came from my observation. When I started to work in CF more than 20 years ago, we were not seeing what I would call older people with CF, those people that were, let's say, around age 40 and things like that. So we took, in our cohort, we observed that we had close to 50 patients that were at the beginning around their early 30s, and that we were able to follow for 10 years. So the question there was, if diabetes occur, is it related to a progression of insulin resistance on a longer time frame than a previous study, or is it the occurrence of insulin resistance? And again, those people were very poor insulin secreting patients, but they didn't progress worse. It was bad at the beginning, it remained bad at the end. However, in the one who developed diabetes, we saw the occurrence of insulin resistance. And by the way, this is exactly, we have very few mice studies studying older mice to try to recapitulate what we have, the labs, because it's costly to keep mice, tend to always study young mice, but there is at least one study actually recapitulating exactly the same thing. So once again, insulin secretion is central, but maybe additional insulin resistance is there. And we have a paper, it's unpublished. We are in the final phase of writing that paper, where in the cohort, the overall cohort with 300 patients, we looked to the combination of being low or high insulin sensitivity, secretion, just dividing the cohort by the median, or high or low estimated insulin resistance, again dividing by the median. And the lower the curve is, the less you have chance to get out of diabetes, so it's kind of survival curve. And actually, after 15 years, approximately 80% of the patients who had both some degree of insulin resistance and poor insulin secretion actually became diabetic, where the people that had only low insulin secretion, the risk of becoming diabetic was far lower. Again, it's not published, it has not been peer-reviewed, so take this with a grain of salt. Final things, and this will be very brief because actually this will be largely discussed in the next talks. What are the potential implications for management? So we know from outside of CF, but the example I kept here, some of them are existing in CF, that insulin resistance can come, for example, of steroids, exacerbations, some weight gain, and I remind you that weight gain is now a new problem in CF. I was not trained at all to speak about weight gain in CF, and now this is something that we do discuss at the consultation. We even sometimes say, you need to lose weight, which a few years ago would have been considered as completely crazy. There is a single small study actually from our team showing that a physical activity program do improve some indices of insulin resistance with some improvement of glucose tolerance, small numbers, but CF specific, and we don't have more than this, and we all know that training people with CF is not easy. And there is at least one study with CFTR modulator and good measurement of insulin sensitivity showing some improvement. What we don't know specifically in CF, but have been proven outside of CF, is that diet quality and other things we were not speaking of a few years ago and that we might need to speak could improve insulin sensitivity, weight loss, could also improve this, and some anti-hyperglycemic agents, which will be discussed in another talks, can also play favorably either directly or indirectly through weight loss on insulin sensitivity. So in conclusion, there is no question that reduced beta cell function is absolutely key to develop CFRD. There is no question this is the driving factor. However, in such context, when you are always limited, for example, you have a car, you don't have good tires, and you live in Quebec in the winter, well, if there is no snow, that's okay. But there is a bit of snow, which would be here in my example, insulin resistance. It's not going to be okay to climb the little climb you have in front of you. So in this, it might be important. So there are probably some of the patients that do have some insulin resistance. It exists in some patients. We're quite sure of this, even though our tools are not perfect to estimate this. And by the way, it's probably useless to try to estimate this in clinic. Even in type 2 diabetes, there is no proof that measuring this, asking for insulin, trying to compute a score is helping you to make some choices. You probably need in those patients to have a closer look to their glucose tolerance or intolerance. And if what is true in the general population, for example, that insulin resistance is really associated with some cardiovascular risk factor, we might look to this. For example, those people with CF becoming insulin resistant might have more risk for hypertension, for example, or some lipid abnormalities. And we do now have some paper in CF showing that the trends are not favorable, though most of the people remain in a normal range. We are not going into the good direction. Physical activity, lifestyle intervention needs to remain cornerstone of our job. We need not to jump immediately on any drug that is available. So increased physical activity beyond all the other benefits in CF is probably beneficial for glucose tolerance based at least on one single study, but it makes sense. In some selected patients, weight loss and or improved food quality, diet quality, probably also makes sense. This is a new frontier. We were not speaking about this. Now, some agents might be recommended in some patients, and I was unfortunately yesterday stuck for plain problems. I was about to present the upcoming Canadian CFRD guidelines. We will advocate that there might be a place for some agents in some patients, and that not everyone needs insulin as we were thinking away. And now there is all that new thing about possible impact of CFTR modulator. Thank you very much. Merci beaucoup.
I think we can take a few questions that are on the app. There's a question from Jagadish Ulal. There is a paradoxical increase in glucagon in type 2 diabetes. What role does glucagon play in the pathogenesis of CFRD?
Short answer, we don't know. We do know that some of the medications that are used for type 2 diabetes tend to suppress glucagon or to reduce glucagon when it's inappropriately high. Another question that could be raised, would those medications could prevent a patient from fighting against hypoglycemia from type 2 diabetes? We believe no. So we don't know exactly what is the place of glucagon. And I believe some patients also have glucagon insufficiency when you look from your clinical expertise in terms of risk of, for example, hypoglycemia during exercise really looks like type 1. So I don't believe it's a major role, but we don't exactly know.
Thank you. So we can probably take, so there's another question from Kathleen Beshan about any consideration for exercise with CF patients and checking blood glucose before and after exercise. For our CF patients, inpatient exercise seems risky at times due to fluctuating glucose levels.
I would say it's mainly for the patient that are insulin treated, that would have repaglinide or any kind of other sulfonylurea. I mean, so part of the question was, do you need to measure blood glucose before and after? If the patient is insulin treated, definitively, and there is a large place now for technology. If the patient has no known CFRD or glucose intolerance, it's already so hard, that disease, that I would not advocate for this outside of a study. We do know from a single small study that regular training do improve glucose tolerance, and it seems to be mostly by reducing insulin resistance. So, but I don't believe you need to measure glucose specifically for this if there is no risk of hypoglycemia related to a drug in place.
I would love if you comment, and you've talked about measuring insulin resistance, particularly in setting of research, and then some of the common outcomes that we report are not well validated in patients with CF. What do you think in future studies would be a good sort of measurement for CF insulin sensitivity in CF patients, knowing that we do a lot of OGTTs generally in many of the big longitudinal studies? Any particular sort of OGTT-based outcome that you, when you experience, you feel is better than others?
Yes, we've used a lot of indices. There is one, the main author is Michael Stumvold, which I think intellectually might be more suitable because it integrates BMI, the body mass index. So I felt that by using this, we would not bias toward other measurements that could do this. But frankly, there is, to my knowledge, no study that have validated against euglycemic hyperinsulinemic clamps those indices. There is quite a lot, a bit too much of on those indices, Stumvold, Matsuda, Bastard, whatever. There is a lot of them. So we need to try first to use the same indices from one study to another. And another big thing that is not related to CF is that insulin measurement is not standardized. So from one lab to another, and even in your same lab, because it can become cheaper at some point than they want. So the insulin measurement from one hospital to another is not the same. So we have major problem to compare studies. We're just like in middle age in that field.
We've had good responses in the app. Maybe we can take one more question. To what extent do you think these changes in sensitivity, insulin sensitivity, are related to changes in CF care and also weight gain?
I strongly believe that weight gain will lead or drive some insulin resistance. There is one paper by Anne Bonnour in Clinical Nutrition on this. This might trigger in some patient diabetes. So yes, weight gain is beneficial to a certain extent, but at some point we will have to live with some side effect of weight gain. And I believe it's going to be just like in the general population. Some patients will develop a bit earlier diabetes, and this leads to the question, in those patients, will we need to suggest some weight loss, some food quality changes, and or use some drugs used in type 2 diabetes, and then fight with the insurance that yes, she is living with CF, but that we want to use, I don't know, GLP-1 analog and so on and so on. And this will be alluded in other talks. And do we have risk related to this? But in my usual care, it is fighting with the insurance to say, this is a strange form of diabetes. I know better than you, and yes, you might leave me use that drug. It's a bit more polite than this, but that's my summary. So let's to put it differently. I mean, we don't want insurance to limit some drugs related to either type 1 or type 2. They need to correspond to diabetes with some specific characteristic. Otherwise, people with CF will always be excluded from getting a pump or a CGM or whatever other drugs. That's my political message.
Good comment. What I've been doing is I add type 2 diabetes as a diagnosis along with CFRD to make the criteria, because if they're developing phenotype, I think it's fair to add this, I mean, at least for the insurance purposes, because when you try to argue in a nice way, they don't really listen. They just look at the ICD code,
Yes.
unfortunately.
All they want is the code.
Exactly. Thank you very much.
Thank you.
So my name is Amir Mohit. I'm an adult endocrinologist at University of Minnesota. So, and I'll be talking about what to expect and what are we seeing in the era of highly effective modulator therapy in the context of CFRD. All right, so here's the outline of this talk. I'll initially talk about overweight and obesity in CF. I think that's important to discuss as we're discussing in the context of risk of type 2 diabetes. Then I'll talk about what we sort of know about the impact of highly effective modulator therapy on metabolic outcomes. And going forward, I'll use the abbreviation ETI for elexacaftor, tezacaftor, ivacaftor. And then I'll talk about diabetes-related complications, and especially in the context of a highly effective modulator use, and then this emerging phenotype of CF-related diabetes with features of metabolic syndrome. So let me start off with a case from my clinic, this is a 32-year-old patient who has pancreatic insufficiency and has been on ETI for about 18 months and has done pretty well overall from a pulmonary point of view. His father has history of type 2 diabetes and coronary artery disease. And he was diagnosed with CF-related diabetes in his early 20s, and now he's managed with an insulin pump. He requires from a recent clinic visit and his pump download an average about 88 units of insulin every day. His BMI is 31, and since starting ETI, he's gained about 30 pounds of weight. His blood pressure is a little high on the most recent clinic visit, and he's already on lisinopril, as he has history of positive microalbumin And he had his annual labs done recently, which showed an A1C of 8.4%. His LDL was 121, a fasting triglyceride of 310, and HDL of 42. So here are some of the questions that he wanted to sort of bring up for this clinic visit. He's clearly concerned about the ongoing weight gain and increase in insulin requirement. He's wondering if he should be taking diabetes medication that promote weight loss, similar to what his father is taking. And he's also sort of concerned about his rising cholesterol level over the years. And he's wondering if, since his father has coronary artery disease, what is his risk, and if he should be thinking about preventive or cholesterol medications in terms of cardiovascular risk. So these are data I'm sure you're very familiar with. This is the median BMI in adults with CF from CF registry over the last 20 years. As most of you well know, the CF is traditionally associated with malnutrition, with sort of intense emphasis on nutritional augmentation and really great advancement in medical therapies. It has really significantly reduced the prevalence of malnutrition. However, with this success, there's also a rise in obesity and overweight, which is, as the previous speakers also alluded to, has started to resemble the global trend of obesity in general population. And here on the left is data from a single center in adults with about 500 patients at University of Minnesota, showing that the prevalence of obesity and overweight was about 33% in the adults in our CF center. And if you look at CF registry data, the prevalence of obesity and overweight has more than doubled over the last 2 decades. And these data are pre-ETI data. I'm sitting in some of the other sessions during this conference. I heard at some of the CF center, the recent rates is actually close to 40, and one actually mentioned in the low 40s prevalence of overweight and obesity in adults with CF. So this trend may further increase with the modulator therapy. So what about, so overweight and obesity, the health consequences of overweight and obesity are well known in general population, and it increases number of risk of medical morbidities and also increases mortality. So individuals who are overweight and or obese are at increased risk of issues like hypertension, type 2 diabetes, lipid abnormalities, fatty livers, risk of cardiovascular or disease. And insulin resistance tends to be a characteristic feature in this sort of spectrum of metabolic disorders. And type 2 diabetes is strongly associated with obesity, and more than 80% of the cases of type 2 diabetes can be attributed to obesity. So what about the impact of overweight and obesity in CF? So clearly, what I think the question is overweight and obesity detrimental for patients with CF? So these are data from CF registry showing the strong positive association between nutritional status and lung function. And as you very well know, that the low BMI is associated with lower FEV1 and increase in mortality, and increased weight has generally been considered favorable in CF, correlating with improved pulmonary function and survival. However, it is unknown if there is an optimal upper limit of BMI in CF. If you look at most studies, they don't really show continued benefit of increasing BMI on pulmonary function. It seems to be a cutoff around 28, 29 or so in most studies. So who are the people, which people in CF who are at increased risk of being overweight or obese? And again, overall, we have limited published literature in this area, but clearly people who have milder mutations, who are pancreatic sufficient, are at increased risk. CFTR modulator use have been associated with increased weight gain. And also, having said that, people who have severe mutations and who are pancreatic insufficient, obesity and overweight is also very common in that population as well. Now, coming to adverse effects of overweight and obesity in CF, again, we have very limited published studies. So far, studies are showing that there's a higher rate of hypertension in people who are overweight and obese. The LDL levels are higher. having said that, these numbers, even though they're higher compared to what they were before, they're still not in grossly dyslipidemic range as we would expect in something like type 2 diabetes. Higher triglyceride and also fatty liver has been associated with increased BMI in people with CF. Now, how about the impact of highly effective modulator therapy? And when I talk, I'm probably just be focusing on data from ETI and ivacaftor. And we are just beginning to understand the impact of highly effective modulator therapy on metabolic outcomes. In terms of ETI, studies have consistently shown weight gain, and we're showing that more and more people are now kind of, if you use the traditional cutoff for BMI, are getting into the overweight and obese category. There's increase in blood pressure, resulting in more people being diagnosed with hypertension. And as we mentioned, there's also increase in LDL and total cholesterol levels. How about glycemic outcomes? I think that's been something, that area that particularly a lot of interest, particularly for endocrinologists as well. And there's really, so this is a summary of results of different glucose outcomes, and this is only based on what is published. And we have somewhat limited data which has been published, but if you look at, the results have been pretty mixed. Studies have looked at outcomes based on glucose tolerance test or A1C or continuous glucose monitor-based outcomes like average sensor glucose or time in range. And some studies have shown improvement, others have shown no change, but the published literature is really limited by either small sample sizes or very broad age range, short follow-ups, have a mix of category of glucose tolerance. We've seen Dr. Kelly presented some data from the PROMISE study showing some promising signs, maybe improvement in A1C and fasting glucose or early insulin secretion. The group from Denmark has an abstract showing improvement in A1C. So I think we are just sort of at the early stages of this early data. We'll know much more in the coming years. And there's an abstract session this afternoon that I just want to plug in, which will actually review those abstracts if you're interested. Similarly, in ivacaftor study, there has been proof of concept studies showing that improvement in glucose tolerance as well as insulin secretion, and studies related to A1C as an outcome have shown mixed results. Interestingly, the large observational data from the US and the UK registry demonstrates a lower prevalence of CFRD among CF patients treated with ivacaftor, 5-year follow-up compared to untreated control with sort of similar genotype severity. So that's really interesting, and it will be interesting to see if we see a similar trend in ETI in the coming years. So what are the potential mechanisms by which highly effective modulator therapy could impact glucose metabolism? And this is a figure from a very nice review by Dr. Marjana and Dr. Larsen-Odi, looking at different mechanisms of how this therapy can affect glucose metabolism. So potentially, it could lead to increased insulin secretion, either through direct or indirect effect on the CFTR, of the CFTR corrector on islet. The indirect effects could include maybe improvement in exocrine pancreas function, or have beneficial effect of intra-islet inflammation, or maybe positive effect on the incretin system. Similarly, reduction in systemic inflammation, fewer pulmonary infections, increased physical activity can improve insulin sensitivity. So these are could be the potentially positive effects. On the flip side, if patients are gaining weight and there's more obesity and overweight, that may lead to increase in insulin resistance. And one important aspect of all this that we've been a theme that we've heard at other symposium as well, it may be different for people depending on their age group and where they are in terms of their exocrine or endocrine pancreas function when the CFTR modulator therapy is initiated. So this is a figure showing the prevalence of different extrapulmonary complications with aging. And as you can see, that the burden of extrapulmonary complication increases as people with CF get older, and really diabetes emerges as the most common complication as people age. And Dr. Blackman showed these data, again, another way of looking at prevalence of CFRD with age. So unless the modulators change this trajectory, this prevalence of CFRD may continue to increase as people live longer. Now, I think both of my previous speakers have really done a great job explaining the mechanisms underlying CFRD, so I would not sort of go into this slide in much detail, but just sort of highlight, as we contrast it with type 2 in the next few slides, it is a multifactorial disease, and it's heterogeneous, and different factors playing more or less of a role in individual patients. However, again, insulin deficiency is the key factor due to beta cell dysfunction or beta cell loss, and other factors like incretin hormones or genetic susceptibility, and insulin resistance with aging or obesity playing a role in development of CFRD. In contrast, type 2 diabetes, again, this is, as we heard earlier, is the most predominant cause of diabetes worldwide, and it's also related to impairment in beta cell, but here insulin resistant may play a higher role as compared to CFRD, maybe over lifetime. And many of the other comorbidities that we see in type 2 diabetes are likely also insulin resistance play a major role in those comorbidities. So how about now coming to the complications related to CFRD? I think Dr. Blackman had briefly sort of mentioned this. In CFRD, the nutritional pulmonary consequences of diabetes are great concerns, as CFRD is associated with weight loss, lung function decline, and increased mortality, and which is thought to be related to the catabolic effects of insulin deficiency. In terms of microvascular complications, they are similar to other forms of diabetes. However, it is thought to be less severe in people with CFRD. And then microvascular complications like heart attack or stroke are thought to be rare. I think the next important question is, how does the introduction of highly effective modulator therapy may impact these complications in the coming years? I think it'll be really interesting to see if, as our patients are doing much better overall, better nutritional status, better lung function, would we still see the same relationship between CFRD and nutritional outcomes? And as early insulin treatment has been a major sort of goal because of the positive impact on those outcomes, would that relationship still be there, or some patients may not need that anymore? So that will be something that we need to sort of look into or study more in the coming years. In terms of microvascular complications, as people are living longer and they're developing maybe other comorbidities like hypertension, which may also have synergistic effects on this complication. So we may see increased rate or increased severity of these disorders. And similarly, I think macrovascular disease, I think we may start seeing more of this as again, the most important risk factor is aging. And now, besides that, we are also seeing more of complications like obesity and dyslipidemia and hypertension. So that may also change in the coming years. So in terms of macrovascular complication, I just wanted to highlight a recent case series that was published by Dr. Sunduk. It has a case series of 6 patients with CF who actually presented with very typical symptoms of acute heart attack, and they had acute MI and required coronary stenting. And these cases were collected from 4 different CF centers, and 5 out of 6 of these patients had CFRD. I think the 6 probably also had CFRD, was just not diagnosed. 4 out of 6 had hypertension. But interestingly, if you look at the bottom row, the LDL levels are low in 5 out of 6 of these patients. So the lipid profile of these patients are not what we typically see in people with, for example, with type 2 diabetes who have coronary artery disease. So here is sort of a figure showing some of the traditional risk factors and potentially CF-specific risk factors for atherosclerotic heart disease. If you look on the left, on your right, actually, the traditional risk factors, which are typically not common in CF, are becoming more common, including aging, hypertension, obesity, dyslipidemia. And on the left are some of maybe the CF-related risk factors like chronic inflammation and oxidative stress, high salt fat intake. And it is possible that now with increase in traditional risk factors, some of the CF-specific risk factors may even act sort of synergetically, and we may promote atherosclerotic cardiovascular disease. So now coming to this emerging phenotype of CFRD. So again, sort of, I think Dr. Blackman also reviewed this nicely. So here we have the type 2 diabetes and what I'm calling the classic CFRD. So as we've reviewed during this session earlier, that the main defect in classic CFRD is the insulin deficiency. And even mild insulin resistance playing a role. However, in the classic CFRD, the features of metabolic syndrome like obesity, hypertension, dyslipidemia, insulin resistance are very rare, and these patients don't develop macrovascular complications, and we treat them, the guidelines say treat it with insulin, so that's been our thing. As compared to type 2 diabetes, where we see that the metabolic syndrome features are common, macrovascular complications are common, and we use a number of different medications besides insulin to treat type 2. So I think Dr. Blackman alluded to this terminology as to what do we call this new phenotype? Is it CFRD? Is it type 2 diabetes? And I think it's neither. I think it's not the classic CFRD. And these patients, even though they metabolically resemble type 2 diabetes, they still have the underlying exocrine pancreas damage and loss of islet cells. So it's not sort of in that way a classic type 2 diabetes either. But I think more than terminologies, I think it's more important that we understand with this new phenotype, what is really the risk of comorbidities and complications in the future? Would these patients be higher risk of now developing cardiovascular disease that we have not seen before? And how do we optimally manage it now? I mean, I think going forward, we need more longitudinal studies to really examine the efficacy and safety of medications that are commonly used in type 2 diabetes, which promote not only weight loss, but also have beneficial effects on kidneys and cardiovascular risks, such as GLP-1 analog and SGL2 inhibitors, maybe metformin. And Dr. DeSimone is going to talk about these medications a little bit more. So I think this group of patients, I think we need to start cautiously and individualized care and individualizing care, consider some of these medications. So in summary, overnutrition is a rapidly growing problem among people with CF, sort of mirroring the obesity epidemic that we see in general population. Highly effective modulator therapy has been associated with increase in weight, higher blood pressure, and higher LDL. However, the long-term impact of this therapy on metabolic and glycemic outcomes are unknown. This new phenotype of CF-related diabetes with metabolic syndrome is emerging, and we really don't have much data to support optimal management. People with CFRD may be at risk of cardiovascular complication in the near future, and really, as I mentioned, I'll just repeat here, there's more research. It's really important more research is needed to examine the role of type 2 diabetes medications like GLP-1 analog or SGL2 inhibitors, particularly in overweight and obese patients with CFRD. Well, thank you very much for your attention.
Thank you, Amir. That was great. So we have some questions in the chat. So let's see. We have one here. Do we know the pattern of fat distribution as people with CF begin to gain weight? Is there, oh, it just moved. Do we know if there's more visceral fat compared to peripheral fat?
I think that's a really important question, and thank you for highlighting the importance of visceral fat. I think when we talk of obesity, it's really important to understand the fat distribution plays an important role in risk of metabolic disease and insulin resistance, so it's the visceral fat which is more pathogenic. I don't think we know the answer to that question. I think there are ongoing studies which are looking at body composition, and hopefully we'll know more, particularly in the context of use of highly modulated therapy. So yeah, it's a great question, but I don't think we know the answer.
Yeah. Here's another one. Thank you for this talk. Do you think there should be CF-specific cutoffs for overweight and obese instead of using the CDC BMI cutoffs?
I think that's a really, really great point, and I think I was alluding that a little bit. I think BMI, as we understand, I think the risk of, clearly the risk, there is some beneficial effect of BMI on pulmonary function, even in the early categories of what we call overweight and obesity, and we don't really know of if a BMI of 26 or 27 is detrimental for patient with CF. So maybe, as we know, generally, if you look at general population, based on globally, people use different cutoffs in different populations based on their risk. So I think that may be applicable to CF as well. But we really need more data and research to figure out what is the optimal range. I think we certainly have some the guidelines about the lower limit, but upper we don't know. But I think that's a really good point.
Wonderful. Here's one. Do you think that lipoprotein subparticle analysis would be helpful in these patients with low LDL and HDL?
Great point. Absolutely. I think that's again a point that I did not address. I think LDL as a number is important. Obviously, we've known in larger studies. However, even knowing the subparticles, which can be more atherogenic, even in the context of low LDL. So I think that could be a great research project to see if these, even if the numbers are lower, these particles may be more atherogenic in CF. So, yeah.
Do you have recommendations for adding screening for metabolic resistance in patients with CF? There were a couple of questions kind of pairing into that, like do you routinely draw cholesterol labs? When would you recommend it? Would you do it based on BMI, A1C?
So I think that's again, a really good question. I wish I had better data to answer all these stuff, but I'll do sort of comment on what our practice is. Certainly in our CF center, all adult patients get us a lipid profile every year with their annual labs. I don't know if it's really needed in everyone, but we do. But certainly I would recommend, obviously, people who have diabetes, CFRD, people who are post-transplant, people who are overweight, obese, to consider screening for lipids. Mm-hmm. Is there something I missed in that?
No, I think that's good. All right. We have time for a little bit more. Have you seen a shift in diabetes onset prior to highly effective modulator therapy, and do you think it will prevent CFRD onset in the future? That's
Great.
a hot topic.
Yeah, that's really a good question. I think it's too early to say for ETI. I think we showed some data about the Evacaftor in registry data, but hope in the coming years we'll see if that is affecting the prevalence or age of onset. I think that's we don't know that yet. Second part.
Do you think it would prevent it in the future?
I think that we all hope that it would do, but I think it's really in people who already have pancreatic insufficiency and this, at that situation, it's probably less likely that it'll prevent. It may be more effective, and I'm just speculating in maintaining. Maybe if it started really early, or even in utero, for example, that I think whether the damage to the exocrine pancreas early on is really one of the main sort of factors that may prevent it from really, truly preventing it from happening, probably.
Okay. There are others, but maybe we'll leave some time at the end, too, for some more general questions.
All right,
Because
great.
I think we're doing pretty good on time. Is that all right?
Okay, so we can maybe we'll go on to our final speaker, and then we'll address, if you have whatever time we have, we'll do the final question.
Wonderful. Well, I'm Marissa Desimone. I'm an associate professor of medicine, as I said earlier, and I'm an adult endocrinologist at SUNY Upstate Medical University in Syracuse, New York. And I'm really excited to be here today. I want to thank Dr. Larson-Odie for inviting me to do this. So thank you, and so happy to be back together. Isn't this nice? What a difference. All right. So today I'm going to be talking about the use of type 2 diabetes medications with treatment of CFRD. I do have a grant from the CF Foundation that has supported me over the last 3 years, so I want to give a special shout out to them for that, but it doesn't really pertain to the content of my talk. So as our wonderful speakers have already gone over in wonderful, beautiful, and intelligent detail, CFRD is the most common extrapulmonary complication of cystic fibrosis. Historically, this disease has been associated with significant increase in mortality that was primarily related to deterioration in nutritional status and pulmonary function. And as they've said, and we know now, that this is seen typically in patients who are pancreatic insufficient. I'm not going to belabor this because we've had some beautiful talks already, but this is primarily due to impaired insulin secretion, and there's an estimated loss of about 50% of the beta cells that come along with the fibrotic changes of the pancreas and islet cell inflammation. But as they've already said today, there's a lot of other additional factors that play a role in the development of this disease. We know that there's poor correlation between clinical diabetes and degree of islet cell damage, and the degree of islet cell damage does not really differ in people who develop CFRD and people who do not develop CFRD. So clearly there's a lot more going on. Now, according to the guidelines, insulin is the only treatment recommended for CFRD. And we know that insulin treats hyperglycemia, but more importantly, for that classic sick CFRD patient, it was important to improve patient weight and to improve protein anabolism, and insulin use had been shown to improve pulmonary function and survival. Keep in mind that CF survival has been closely connected to nutritional status. That has been the ultimate goal in care for patients. And so we were looking to improve patient outcomes and nutrition and not just hyperglycemia. And it should be just mentioned that there are no large randomized controlled trials that have compared insulin regimens. Unfortunately, insulin treatment is something that is not always easy for patients. Multiple daily injections, frequent blood sugar monitoring, having to learn how to carb count carries a very heavy burden in patients who are already dealing with a very heavy burden of chronic disease. And so that can really relate to difficulty with maintaining adherence for a time-consuming treatment regimen. And then, of course, there are patients who really just don't fit that inside that box of your typical sick CFRD patient. We have people who are now normal or have high BMIs. We see patients who have extremely minimal insulin requirements but still have some hyperglycemia. We can have patients who are developing a lot of hypoglycemia or who have excellent and stable lung function now. And so really it's time to think about new ways of approaching this new healthier, thank goodness, population, and trying to come up with some new ways of dealing with these challenges. Unfortunately, we have really limited data for non-insulin therapies, and that is like such an understatement when you see the numbers that I'm going to present to you today. We're really kind of flying by the seat of our pants with a lot of this, but lots of interest in finding new ways to treat these patients. So when we think about diabetes medications in general, there are a number of different classes of medications that are available for use, and they have different mechanisms of action. They work across a variety of different target tissues in a variety of different ways. And so when you're thinking about choosing these agents and deciding if you think it would be appropriate for your particular patient, you really do need to take into account that individual person and all of their complexities and nuances, because there's just so much to consider in a medically complex individual. So let's discuss what these different options are. The first medication I'm going to talk about today is metformin, which is extremely widely used in treatment for patients with type 2 diabetes. This is a medication that improves insulin sensitivity and can reduce hepatic glucose output. We do have some data available in the CFRD population. We have one retrospective review looking at 18 patients. And in this group, 6 or 33% had a normal BMI, 10 were overweight, and 2 were obese. And they had 5 patients who were treated with metformin in combination with insulin, and then the remaining 13 patients were receiving metformin alone. We also have a non-randomized open observational study where they had 6 patients that were prospectively followed on metformin therapy. And with both of these studies, we saw that metformin was well tolerated. There were no adverse effects in either groups of patients. They did not have weight loss. There was no noted decline in FEV1, and there was no weight benefit. But that's not surprising with metformin as a drug class. If we compare that to what we see in the type 2 diabetes population, metformin is not usually associated with weight gain. It's typically considered to be either weight neutral or have a very mild, maybe 5-pound weight loss. So I do think that there's some potential for use in metformin, especially in overweight and obese individuals with cystic fibrosis. Certainly could be considered as an add-on for patients who are on higher doses of insulin therapy and perhaps not meeting glycemic targets. It should be noted that metformin can have some GI side effects that can sometimes be a limiting factor in the type 2 population. Things like nausea or diarrhea or abdominal pain can come up. Also, there has been a historic concern about lactic acidosis, especially in the setting of hypoxia. The actual incidence of lactic acidosis is really quite rare, but would probably not be appropriate for people who have very compromised lung function or are using oxygen. And it does require dose adjustments in people with renal disease and should be avoided in people with severe liver function. Now, the thiazolidinediones are an interesting class of medication. These are termed TZDs because that word is just a mouthful. But these are from a class of medication called peroxisome proliferator activated receptor gamma agonists. And the way that they work in diabetes is to decrease hepatic glucose output and lipotoxicity, and then they also help to improve glucose uptake and insulin sensitivity. I think these were really very interesting at one time because there was thought to be potential anti-inflammatory benefit with this class of medication, which has obvious appeal in a group of people who have a lot of lung inflammation. We don't have any human data regarding this class of medications' anti-inflammatory properties in cystic fibrosis, but there's some animal data that exists. Again, we had this one open-label, non-randomized prospective study looking at 6 CFRD patients who were treated with TZDs, and they listed that they had no adverse effect on BMI or FEV1. With the TZDs, though, for those of you who are adult endocrinologists in the room, you probably already know that this class of medication really has been largely phased out for use in people with type 2 diabetes. They were taken off the market in some European countries because of some concerns related to congestive heart failure, potential risk for increase of fractures, and some medications in this class have also been linked to hepatotoxicity. From a CF standpoint, these are probably not a great choice when you're considering alternative therapies in helping your patients. Sulfonylureas are a common and very inexpensive class of medication, which is nice because so many of our newer type 2 diabetes medications are incredibly expensive. So these have been around for a long time, and they work by increasing insulin secretion by the pancreas. Again, we have this one non-randomized, open-label, prospective study looking at 6 patients who were treated with sulfonylureas. In this study, they noted no adverse effect on FEV1, and something that I found quite interesting actually was that they said that this was weight neutral, and that's not usually what we see when we use sulfonylureas in the type 2 population. Traditionally, if you're getting good insulin secretion, you expect weight gain because insulin is an anabolic hormone. And certainly in patients with type 2 diabetes, we typically see weight gain with sulfonylureas. So this sort of brings up the question of whether or not in this small study, patients were able to mount a good insulin secretion with this medication. But obviously that's an unanswered question. We also have a retrospective review of 24 CFRD patients. 13 of the patients in this had to be converted to insulin after 18 months, and of the remaining 11 participants in this study, only half could continue sulfonylurea to average of 2 years before they had to be converted to another agent. So again, raising that question of whether or not this medication would be adequate to control hyperglycemia in this patient population. And that may depend on a lot of different factors that weren't explicit in these studies regarding, how early on these patients were in their endocrine pancreatic insufficiency and whether or not this could be more effective if used at a different time in their disease process. So it's really unclear what the glycemic benefit would be, and it's also unclear what any benefit beyond glycemic control would be. The other thing that I think is worth mentioning about this class, and I didn't know this actually until I started looking into the studies to do this talk, was that sulfonylureas may bind to and inhibit the CFTR protein. And that obviously could be a huge problem because we don't want to interfere in treatment of cystic fibrosis. And so I think there's a number of different reasons why this sulfonylureas may not be an attractive option. Now, repaglinide is the medication other than insulin that we have the most data on for use in patients with CFRD. That being said, there are only 2 systematic trials. One trial looked at 75 patients aged 10 or older. These patients were randomized either to repaglinide or pre-meal with regular insulin. And they were termed as being asymptomatic regarding their diabetes and being newly diagnosed with their diabetes. In this study, they found that the insulin group had greater BMI improvement at 12 months, but at 24 months, neither agent was effective at promoting durable weight gain. There was no difference between hemoglobin A1C or FEV1 between either agent. And then in another study looking at 81 patients with CFRD who did not have fasting hyperglycemia, or patients who were diagnosed as having severe insulin glucose tolerance. And the definition in this study was having a glucose greater than 200 during the OGTT, but the 2-hour value was between 180 and 199. These patients were randomized either to pre-meal insulin with aspart insulin, which has different pharmacokinetics than regular insulin, repaglinide, or placebo. All of the patients who were included in the study had a decline in BMI in the year prior to study enrollment. And so this is really a different patient population than the first study. And it's important to, I'm sorry, I skipped ahead. So in this group, insulin had sustained improvement in BMI at 12 months, but that was seen only in the CFRD group, not in that severe insulin glucose tolerance group, or impaired glucose tolerance group, pardon me. And there was no change in A1C for either group. So I think it's important to just mention these studies are very different. They clearly had different patient populations. They used 2 different types of insulin, which have different ways of working and duration of action and onset. And they also use different dosing schedules. So they're really not directly comparable. But I think that what we can say at least is that with repaglinide, we don't see a benefit with BMI. So if you have a patient who needs to gain weight, this is probably not a good choice. And there was some hypoglycemia in the repaglinide group, but it was mild. Now, acarbose is a medication you don't hear about too often, but I wanted to mention it because it is a type 2 diabetes medication. This is an alpha-glucosidase inhibitor, and it works to delay hydrolysis and subsequent absorption of carbohydrates. And it has been shown to improve postprandial hyperglycemia in type 2 diabetes patients. We do not have CFRD patient data, but we do have some CF data. So there was one study looking at 12 patients who had impaired glucose tolerance, and they were put in a crossover trial. They were exposed to both acarbose and placebo, and they did have lower glucose and insulin levels postprandially. That being said, 67% of the patients had GI side effects, which is a lot. GI side effects with acarbose are not unusual. Patients can get things like diarrhea, nausea, loss of appetite, abdominal cramping. In the type 2 diabetes population, these side effects tend to decline over time. And in type 2, acarbose is not associated with weight loss, but we don't know how it may behave in CF or CFRD patients over time because this is all the information that we have. All right, so to switch gears a little bit, I just want to touch on incretin hormones. For those of you who may not be endocrinologists, incretin hormones are secreted in the small intestine. They are part of what is termed the enteroinsular axis, and 2 incretin hormones of great interest are GLP-1 and GIP. These stimulate early insulin release and help to delay gastric emptying, and they, in reference to GLP-1, help to inhibit glucagon. These hormones are responsible for a lot of our glucose homeostasis, and they account for up to 2/3 of our insulin secretion. And this insulin secretion from these hormones is termed the incretin effect. They are both degraded by an enzyme called DPP4, and they have a very short half-life of minutes. So, exactly how incretins change in cystic fibrosis is not completely clear. The literature is not consistent. In CF, active and total postprandial GLP-1 and GIP levels have been reported to be increased, reduced, or unchanged. But we do know that there are a number of different things that can contribute to alterations in incretin secretion, and that primarily is around the nutrient load and the nutrient rate of digestion. So of particular importance in patients with CF, if you have pancreatic insufficiency and you get supplemented with pancreatic enzymes, or if you're adherent with your pancreatic enzyme supplementation, that can help to increase your incretin levels. It doesn't normalize them, but it can improve. If you have hyperglycemia, that can lower levels, and eating a high-fat diet can alter the rate of gastric emptying, which then can alter potentially incretin levels. And at least in reference to glycemia and gastric emptying, these are things that can change over the course of the patient's disease. And so this is possibly a moving target for many patients. So thinking about these hormones and the medications that can alter them, the first one that I'm going to talk about are the DPP4 inhibitors. And again, this is the enzyme that degrades the incretin levels. So when you treat patients with a DPP4 inhibitor, what we expect is an increase in glucose-dependent insulin release. So we have 3 different case reports in the literature of DPP4 inhibitor use. One was in a single patient who had CFRD, but unclear pancreatic exocrine function, meaning it just wasn't explicitly stated in the article whether or not they were pancreatic insufficient. A second case report of one patient with CFRD who was struggling with reactive hypoglycemia, and then 3 patients with CFRD who were pancreatic insufficient. And in all of these studies, we saw improvements in glycemic control in the patients who were treated with sitagliptin. And in the 3 patients who had CFRD and pancreatic insufficiency, they had weight gain. That was a long-term study, 5 to 10 years, depending on which patient. DPP4 inhibitors in the type 2 population are traditionally considered to be weight neutral. So it's not really clear if this was a result of exposure to the medication or just weight gain that often comes with aging and is seen in many people in the United States as we get older. So not really clear, and definitely more studies are needed. Unfortunately, large trials that have been designed looking at DPP4 inhibitor use had to be closed because of a lack of enrollment. So this is the information that we currently have. All right, and then as far as data available for GLP-1 receptor agonist use, we have one case report of one patient who had CFRD with pancreatic insufficiency. This person had inadequate control on insulin. They were on basal bolus therapy and were having both hypo and hyperglycemia, which is not desirable. And what they did was put the patient on a subtherapeutic dose of semaglutide, so half of what is typically considered to be a starting dose, and they found that the A1C improved after 3 months. This is a screenshot from their continuous glucose monitor download where the patient had improved time in range and reduction in both hypo and hyperglycemia. The patient was able to come off of their preprandial insulin and just stay on the GLP-1 receptor agonist and their long-acting insulin. And they also had improvements in their fasting C-peptide levels, indicating more of their own insulin secretion. They did not have GI side effects, but they did have a 2-kilogram weight loss over 6 months. And that is not surprising because weight loss is a class effect of this medication. So that is a really attractive option for patients who are overweight or obese, but not a desirable effect in people who are thin or borderline BMI. We do have some concerns with incretin therapies, namely surrounding pancreatitis. And initially when they came out, I think that this was more worrisome. As time has gone by, the concerns regarding pancreatitis have diminished. But this screenshot is from a meta-analysis that was done looking at the cardiovascular outcome studies and these incretin-altering medications in type 2 diabetes. And at the top, we have the data from the GLP-1 receptor agonists, and you can see that none of the individual studies or on meta-analysis, there was an increased risk of pancreatitis. With the DPP-4 inhibitors, none of the individual studies had an increased risk, but on meta-analysis, there was a 75% increased risk of pancreatitis. I think that that would be more of concern if you're using it in a patient who is pancreatic sufficient. If you have somebody who has already burned out their pancreas, the risk of pancreatitis is pretty low, but a good thing to be aware of. All right, so that was a lot of information to cover in 20 minutes. Where do we go from here? My final slide. Again, just to reiterate, insulin currently is the only treatment that's been shown to reduce morbidity and mortality. We do not have adequate data for non-insulin therapies. What I've given you today was all I could find in the literature. And I think that we have still a lot of unanswered questions. The role of incretins, I think, is promising and very interesting, especially as our patient demographics change. We have no data on the use of SGLT2 inhibitors in cystic fibrosis, and so a lot of questions surrounding that class of medication and how it would work in this group. Also, bigger questions about the optimal management of overweight and obesity and what we should do about patients who have prediabetes, what level of dysglycemia we should be intervening on, and will that make a difference in patient outcomes? So my final thought really is that more research is needed. And with that, I'd like to thank you very much for your time and attention. I'd also like to thank the Envision 2 cohort for a wonderful 3 years of collaboration and learning, as well as my mentors, Dr. Antoinette Moran and Amir Mohit. So thank you.
All right. So, well, thank you for this wonderful talk, Marissa. So I have there's a question about medications that stimulate beta cell to produce more insulin, like repaglinite or sulfonylureas. Would they cause earlier burnout of beta cells? So the concern is using sulfonylurea would further impair beta cell function, and could that actually accelerate CFRD?
I don't think that we have any real understanding of that as far as I know. It's hard to draw a conclusion from type 2 diabetes because the natural course of type 2 diabetes is progressive loss of beta cell function. So I'm not sure I know the answer to that. I know we have some amazing researchers in the audience. Does anyone else know? No? It's a mystery.
How would you address patients? I guess there's a question about indeterminate glucose tolerance. So, patient with glucose indeterminate glucose intolerance, basically high glucose reading at 1 hour, but not normal at 2 hours. Is this indicate delayed insulin response, and does it require treatment?
It does indicate delayed insulin response, and that is something that we see in patients with CF before they develop CFRD and impairment of that early phase. It's unknown whether or not they should be treated and how. And so that is another huge question in this area. Clinically, the way that I approach it is by letting them know that this maybe could be considered a precursor, and you know, if they are overweight or obese, we spend some time talking about healthy lifestyle changes, trying to improve exercise, focusing on not just calorie intake, but the type of nutrition that they're taking in. You know, I think it's very common, at least in my clinical practice, to still see patients who are drinking tons of soda and tons of junk food. And so, you know, we do spend some time talking about those things, but it's been difficult because we don't have guidelines to show us where we should be going with that yet. And so I really just try and take that sort of approach of, you know, this could be diabetes, and let's think about healthy lifestyle. Now, that's if they're overweight. If they're thin, and I'm worried about maybe they're heading down that pathway of CFRD and insulinopenia and needing that anabolism, we talk much more about, you know, maybe checking their blood sugars after high carbohydrate meals at home to see how things are going. At least where I am, we haven't had great luck in getting CGMs for people who have no diagnosis of CFRD, and even with CFRD, sometimes we're not able to get a CGM. So those are the kinds of conversations that we're having, but we don't really have a clear roadmap of what we should be doing.
Okay, how about SGLT2 inhibitors in patients with evidence of kidney disease? So a patient with CF-related diabetes who have some evidence of kidney disease, would you consider using SGLT2 inhibitors?
I have not crossed that bridge yet. I haven't had a patient that I've started an SGLT2 inhibitor in. We have no data. So, you know, that's a hard place to go when you have nothing to base your decision off of. Has anyone else in the audience used SGLT2 inhibitors in CFRD? Yeah, do you want to tell us about your experience? One? For proteinuria. And how did they do? Okay.
So I think the thought is for people, for the non-endocrinologists, SGLT2 inhibitors also have beneficial effect on kidneys. So in people with CFRD who have evidence of microalbuminuria or kidney complication, would you, besides ACE inhibitor, should this drug be preferentially used because of its not only beneficial effect on CFRD, but also in SGLT2 inhibitors? We do have some time, so Rama, do you want to come up and maybe we can do a little discussion, maybe use, we have quite a few questions, so I think that we can address as like a panel, because I know there's so much lack of data and maybe different opinions may be helpful. You can sit there, I can stand there, that's fine. We don't need another chair. Go ahead and sit, we have mics then.
Okay, you sit.
I can maybe address questions to everyone.
Sure.
So a question for Dr. Rammer. Could you comment on the Canadian guidelines and use of non-insulin medications for CFRD?
Yes, if Air Canada would have brought me on time and not 12 hours later, I would have a lot of time for this. I would say that, yes, we are coming with guidelines. Caution has not been endorsed by CF Foundation or Diabetes Canada, which is planned and neither published or peer-reviewed. I believe that three of the major things we will recommend that are not in the current guidelines is first that a person from the CF background should be, every time this is possible, trained for diabetes, and the order is important. It's not a diabetes person that has some knowledge of CF. We believe it's a CF person that would have some knowledge about diabetes, and when this is not possible, to have a clear pathway with someone that is knowledgeable about CF before knowing diabetes. The second thing we are going to recommend is to use A1C, glycosylated hemoglobin, or HbA1c, depending on the country you are, as the first step, and not send to oral glucose tolerance test the people that have a value below 5.5, because at that point the risk of CFRD is so low, and there is those guidelines has been pushed, and we have involved patient partners all the way. They just hate OGTT. They ask us to get away from this. And the last thing we have alluded in that session is that we now believe that not all CFRD patients are for insulin. And as we just heard, very few data. There is probably place for other types of pharmacotherapy. This will be, in my opinion, the three changes compared to what is in the field now.
Well, thank you. I think you mentioned A1C, and there are a couple of questions actually in the chat about A1C. And I'll just, so one is about, so is there any data showing that the highly effective modulators may improve our red blood cell survival? And would the A1C now be more accurate? Now the patients are much more healthier than they used to be. And the concern about turnover and lower A1C, do we is there something that we know about that?
To my knowledge, we don't know, but this makes sense.
Yeah. Yeah. Thank you so much, Dr. Kelly. So maybe a question, maybe anyone in the panel? I wish you had the iPad, Marissa, but well, but so there was a question, I cannot find it anymore, but there was a question about metformin use in pediatric population, and if metformin is started earlier on, would it improve insulin sensitivity, or if that prevent development of CFRD or progression of CFRD? If any of you have, I think you had alluded a little bit, or if either of you can comment on that.
I'm not a pediatrician.
I'm not a pediatrician, but yes, we know from non-CF population that metformin can delay type 2 diabetes. It is among the medications that have shown this. To my knowledge, we don't know for cystic fibrosis. It could be. It makes sense on the paper, but it's always the same. Without a good study and balancing the advantages versus disadvantages, we know it's a cheap medication, and we know that there is no major side effect beyond the GI, which is the important. It was really one explained. So why not? This, adding an additional medication without good evidence, I would be reluctant, but comes always to the point that in CF we rarely have good data.
So there are a couple of questions about GLP-1 analog and GI side effects, and maybe I can sort of comment on that. So again, we have really limited published data, and I know that quite a few of us are using GLP-1 clinically, even though it is not something much published. And I can, in my practice, with Dr. Desimone, we're trying to collect a series of cases. So I have at least now 7 patients on GLP-1 analog. I know Dr. Letman had been using it for a while as well. Interestingly, there's a lot of concern about GI side effects, but my patients, none of them have so far stopped GLP-1 analog because of GI concerns. So they're at least in a small group, and again, this is not any systematic research, but anecdotally, GI they've tolerated quite well, actually, at least in my practice.
Same with mine.
So my go-to drug is just, I think, just because of convenience and also because of the sort of data that is coming up, I'm using more semaglutide. But I've used one patient who, because of insurance issue, I'm using daily liraglutide, but most of them are on semaglutide.
And it's really not only in CF. Start low and go slow with those drugs, even starting those beyond the authorized dose and increasing click by click, for example, for semaglutide. It's not recommended by non-healthcare organization, but it works so well. So start low, go slow, and find the maximum tolerated dose. And exactly as was shown, some patients do great with very small dose, 0.25 milligrams weekly of semaglutide. Some of them, the improvement, a bit like Amir, I have probably 5 or 6 patients, the improvement is quite impressive in some patients. Yeah. Very limited data, but personal experience.
There's another question. Amir. Oh, sorry, go ahead.
We have one patient on liraglutide who pretty quickly after starting had pretty significant exacerbation of his reflux. And so once we started him back on a PPI, he did well with that. So that's one thing, probably a discussion to have with patients.
And just to also point out, all the patients that I have are pancreatic insufficient and are overweight and obese and have long-standing diabetes, and so I'm really using it in select patients who are overweight, obese, with clinical evidence of insulin resistance and high insulin doses. There's a question about teenagers. So again, all 3 of our groups say we may not take care of teenagers, but how? So the case report about the GLP-1 that Dr. Desimone mentioned was, I think it was a young adult. It was not a teenager, right?
Yeah, it was a young adult.
So would you feel comfortable prescribing to teenagers if they continue to have excessive weight gain on highly effective modulator, even in terms of as an obesity drug, irrespective of hypo or hyperglycemia?
Yeah. Again, I'm not a pediatrician. I know that my pediatric colleagues are sometimes using those for patients who are teenagers with type 2 diabetes. So I suppose it could be considered in the appropriate patient.
In the non-CF pediatric population, I know that GLP-1s are quite, they've been well studied and considered safe and are being used quite frequently.
Same in Canada.
All right, I think we have covered. I'm sorry if I missed something. I think thank you so far. It's been a wonderful, wonderful discussion, and I think clearly indicates how important this is.
Thank you all.
Thank you very much.
Thank you.